Hello, my name is Bewley-Taylor and I'm a student rehabilitator here at Cardiff Metropolitan University. Today I will be discussing a rehab practitioner's approach to decathlon, an athletics sport encompassing 10 different track and field events. These can be split into 3 main disciplines: running, jumping and throwing. While this wide breadth of movements allows the athletes to display their full athletic prowess, it also creates multiple stresses and chances to encounter a variety of injuries. Within the following presentation, I will cover the appropriate areas related to decathlon: epidemiology of the common injuries within the sport, risk factors of said injuries, screening tests that can be used to identify relevant risk factors, and rehabilitation exercises used to minimise the athlete's risk of injury. Moving to injuries within the sport, looking to the running events, papers by Segura, Jansen and Abalchi identified Achilles tendonitis, patellofemoral pain and hamstring strains to frequently affect athletes during these movements. Both tendonitis and patellofemoral issues are overuse injuries caused by continuous damage that does not allow the body to fully recover, making these issues common in a sport with a high volume of high impact running such as decathlon. Hamstring strains occur during the high speed running of the 100 metres, during which the late swing phase, where the muscles is put at maximal stretch, which drastically increases the chances of injury. Ankle sprains were found frequent in jumping events by Inoki et al. Due to poor landing mechanics following takeoff, which put excess strain on the ligaments of the ankle, resulting in damage. Within the throwing events, rotator cuff tendonitis is the primary cause of time lost from training and competition. Dino et al. Identified it was a consequence of repetitive eccentric loading of the rotator cuff during the deceleration phase of the throw. Knowing these injuries, we can now look at risk factors that cause these issues. Risk factors are defined as physical characteristics that put an athlete at an increased likelihood of experiencing an injury. The leading underlying risk factor for decathlon injuries was muscular strength, with papers from Brady, Sorowski and Neal all confirming this hypothesis. Weakness of the lower limb musculature, to include the hamstring, quadricep, gastrocnemius and soleus, were underlying causes of hamstring strain, patellofemoral pain and Achilles tendonitis respectively. This being a result of weakened muscles being unable to offload a large number of forces from these structures, resulting in injury. Conversely, poor localised proprioception was mentioned by Hahn et al. In 2015 as the leading cause of sprains, thanks to instability reducing ligaments' ability to absorb torque. Finally, Johnson et al. Identified a glenohumeral internal rotation deficit, or GERD for short, putting an athlete at an increased risk of various rotator cuff pathologies. This is a consequence of the rotator cuff stiffness of the joint capital hyperplasia it creates, which puts excess strain on other structures of the shoulder. Knowing the outcome of these issues, we can now find ways to identify them. Screening tests are used as a means of identifying physiological pathologies, usually conducted in a binary format with outcomes being labelled as either positive or negative. Positive meaning the pathology is present in the subject. A relevant test has been selected for each of the common risk factors for pathologies within decathlon, based on the validity and reliability for each of the risk factors. The following demonstrations will include coaching points and desired outcomes for each movement. The single leg bridge test. The aim of the test is to assess the strength and endurance of the hamstring muscles. A positive outcome would be 25 repetitions, which represents normal, regular muscular function. Begin with a platform between 50 and 60 centimeters in height. With the client lying supine, instruct them to lift their leg and plant the heel onto the raised platform. The knee angle should be between 20 and 25 degrees of knee flexion. Raise the other leg and cross the arms to finish the start position. The client is then instructed to push their heel and thrust their hips towards the ceiling. This motion is then reversed until the glutes make contact with the floor. This motion is then repeated until maximal muscular failure is achieved. The legs are then switched and the test repeated on the opposite leg. The heel raise test. The aim of this test is to assess the strength and endurance of the gastrocnemius and soleus muscles. The positive outcome for this test would be 37 repetitions, which represents normal muscular function for those between the ages of 20 and 29. Begin with your client approaching a wall and standing on a platform that raises their heel to 10 degrees of dorsiflexion. Use both index fingers for support. With the back leg raised, instruct the client to bring their heel as high to the ceiling as they can. Once this is achieved, repeat the motion until the heel makes contact with the ground. Repeat this motion until maximal muscular failure is achieved. Grounds for ceasing the test include back leg being used as support, loss of postural control, and being unable to keep up with the cadence of the test. The unilateral sit-to-stand test. The aim of this test is to assess the strength and endurance of the quadriceps muscle group. A positive outcome for this test would be 24 repetitions, which is an average for a regular muscular function. Begin with a platform at least 18 inches in height. Begin with your client sat on the box and one leg raised. They are then instructed with their arms crossed to simply stand above the box until maximal extension is achieved, and the motion reversed to sit back down again. This motion is then repeated until maximal muscular failure is achieved. A bump and go method is allowed on this test, with failure involving the other leg being used to support, not making contact with the box, and a loss of postural stability. The single leg balance test. The aim of this test is to assess the stability and proprioception of the ankle joint. A positive outcome of this test would be 43 seconds, which reflects a stable ankle in 18 to 39-year-olds. Begin by instructing your client to lift their leg to 90 degrees. They are then instructed to cross their arms above their chest and simply hold this position until they lose their balance. If any of the previous test outcomes were positive and the presence of a risk factor identified, then actions need to be taken. The following exercises have been selected to act as a pre-rehabilitation program to reinforce specific structures and correct any abnormalities so to reduce the athlete's chances of being injured in future. The unilateral remaining chair hold. The targeted muscles of this exercise are the hamstrings, glutes, and abdominals. The prescription for this exercise is 3 sets of 10 seconds per side. Progressions for this exercise include additional weight and a plate row variation. Regressions include limited time under tension, lowered resistance, and a bilateral variation. Begin by instructing your client to take up a position on the GHD machine. Once in the position, instruct them to extend at the knees and hips until a perpendicular position is formed. After this, instruct them to take one leg out of the stirrup to make it a unilateral variation. Now with weight, instruct them to hold the position for the prescribed time frame or use a plated row to add additional resistance. The unilateral 45-degree extension. The targeted muscles of this exercise are the hamstrings, glutes, and erector spinae muscles. The prescription for this exercise is 4 sets of 5 seconds eccentric, 5 seconds isometric, and 5 seconds concentric. Progressions include load and volume, with regressions including reduced time under tension and weight. Begin by instructing your client to take up a position in the 45-degree hip extension machine and taking one leg out of the stirrup to make it unilateral. Following this, with additional weight, instruct them to complete a 5-second eccentric, 5-second isometric, and then 5-second concentric contraction to return to the start position. The eccentric unilateral calf raise. The muscles targeted in this exercise are the gastrocnemius, soleus, and tibialis posterior muscles. Prescription for this exercise is progressions for this exercise include increased volume, time under tension and load, with regressions mainly being a bilateral variation. Begin by instructing your client to step up onto a box, raising into a calf raise position and then taking one leg off of the box. This ensures that it is a unilateral exercise that focuses on the eccentric portion of the lift. Once in this position, instruct them to complete a eccentric calf raise with a 3-second cadence, then using the other leg to assist the concentric, making it a purely eccentric exercise. The unilateral banded knee extension. The aim of this exercise is to strengthen the quadriceps. Tissues involved include the quadriceps. The prescription for this exercise is 3 sets of 10 seconds total time under tension per leg, with 2 seconds isometric, 3-second concentric, 2-second isometric and a 3-second eccentric. Progressions include increased volume and time under tension, with regressions including a bilateral variation. Begin by tying a band around a bench. Once this is completed, attach the band to the client's foot in the appropriate format. They are then instructed to cross their arms over their chest to create the start position. Once this is done, instruct them to extend their leg as far out in front of them as possible at the appropriate cadence. The motion is then steadily reversed to the start position. The wobble board balance. The aim of this exercise is to improve the stability and proprioception of the ankle joint. Active structures of this exercise include the deltoid ligament, anterior and posterior talofibular ligament, and the calcaneofibular ligament. Prescription of this exercise is 5 sets of 20 seconds per leg, with progressions including different movement patterns and squat variations, and regressions including reduced volume and board types. Begin by simply asking your client to step onto the wobble board and hold this position for the prescribed time frame. Pay particular attention to the athlete's ankles, as this can be a prime indicator of instability. As you can see from this example, this particular athlete is extremely stable at the ankle. To progress the exercise, you can introduce back and forward movements, along with circular motions to increase difficulty. Not only this, but unilateral balances and squat variations can be used to increase difficulty. The unilateral catch and pass. The aim of this exercise is to improve the stability and proprioception of the ankle. Active structures include the deltoid ligament, anterior and posterior talofibular ligament, and the calcaneofibular ligament. Prescription for this exercise is 5 sets of 20 seconds per leg, progressions including extra volume resistance and the direction of the ball, and regressions including a football over a medicine ball with volume and keeping the passing simple. Begin with your patient adopting a single leg stance to make it unilateral, and while standing in an upright position, simply catching and passing a medicine ball whilst remaining on the single leg. Make sure they keep an upright torso throughout. The difficulty can then be changed by altering the direction and height of the pass, making the athlete adapt. I hope you found this information useful and intend to use it to bolster your future injury prevention programs. Thank you for watching and happy rehabbing.